Thank you very much, Alan, for the kind invitation. I'm really pleased that besides the guidelines that are coming up, I think we are also poised to be able to move in the era of artificial intelligence and re-examine what can be done in a fast-paced clinical practice where there is considerable cognitive challenges on using guidelines, particularly the complexity of the guidelines and in diastolic dysfunction. And here are some of the disclosures. Right now, we are supported for some of the work based upon NHLBI and NSF grants. And the picture that I was showing is the innovation triad at New Brunswick, where the helix of the innovation center is coming between Philadelphia and New York. So I'm really excited about the opportunity to lead some of the program at New Brunswick. Now, the challenges for the diastolic dysfunction, as mentioned, since 2016 guideline was published, and even the new one that is going to come in, it seems like it's a complex task. And when you look upon the working memory of a person, when you're confronted with, there's always a cognitive overload. And particularly if there are experts, I think it's faster. But if there are novice and people who are just starting in their clinical practices, this is a considerable challenge. So the predominant challenge is how do we apply the expert consensus pathways and take the cognitive overload and avoid errors in mainstream clinical practice. Can artificial intelligence help us with some of these decision supports? The other caveat is that we all understand, while we are seeing our patients, we know that a filling pressure, which was typically used at least in the previous guidelines, and maybe also the consideration for the current guidelines, is a moving target, and exercise sometimes brings in the symptoms. And people who complain of shortness of breath on exertion, and then they are examined at rest, it may not corroborate, and that's the another challenge is how do you get the ability to bring in the symptomatology into consideration for diagnosing diastolic dysfunction, particularly when it is exercise related. And the third point is, and that's been the biggest challenge, is the diastolic function parameters keep on changing throughout the lifetime. So when you use a single cutoff value of 6 or 7 or 8, how do you apply it for a young patient? How do you apply for a octogenarian? And these are also other questions that are perplexing. Could AI and the tools and the lens of the AI help us in this regard? And the question is open for us to examine. With the bringing of the revolution of the deep learning, we saw a tremendous uptake of the industry in using automated platforms. And currently, all of these automated platforms are available in the clinical practice. Many of them are currently being used in clinical practice, which allow us to automate the quantifications. For example, be it ejection fraction, diastolic dysfunction parameters, there is wealth of evidence that they can be directly extracted once the images are made available. So there is no wonder that deep learning is here to stay when it comes to automating the process of measurements and extraction of the data from the images. The question is, how do you put the equation of putting all of this measurement together towards the goal of diastolic dysfunction? Can that be liberated? That's the bigger question. And in that context, it's a big cognitive burden. Even if you examine all of these different parameters, if you look on the echocardiographic parameters and you look at the cath lab parameters, there are tremendous numbers of variables that you are juggling up with. And if you look into, from a data science perspective, from an AI lens perspective, and in general about scientific perspective, there is a conceptual shift that we need to make in. What is function or dysfunction? Well, from a data science perspective, diastolic function cannot be measured by one parameter. We know that there are several features in the myocardial measurements that can move together, and therefore it is a latent state. It's that state of the myocardium which has all of these variables that move in together in one direction or the other. Just like, a latent variable or a latent state is something that cannot be measured with a single measurement. So in the same way, the diastolic dysfunction or function is a latent state of the heart, which cannot be explained by one variable, but has to be used and explained by clustering of different variables. And this is the direction we started examining in terms of AI and its application. And we started looking into clustering of different variables and how do they shift. And some of the earlier work we did showed that it was better than the heuristic, simplistic approach that we use of looking at single variables, how do they move in the decision pathways. And subsequently, we applied also these variables, how do they cluster together and identify patient trajectory over time. And these work are currently clinically not used. However, some of these tools are research tools are available. We have developed a supervised clustering classifier. You can take all of these variables that you measure, and once you put it inside the classification tree, it comes up with a probability of that state being present, dysfunction being present or not. And it has been well validated subsequently in multiple NHL BI clinical trials, where it goes back and shows that these classification of a high probability of diastolic dysfunction or low probability is associated with survival or treatment benefit, for example, in the TopCat trial. So some of this work is available, and this classifier is openly available. It is not for clinical purpose, it's for pure research purpose, but you can input this parameter and get this probability assessment of the state being present. Perhaps in the near future, I think there is a likelihood that we may be moving away from simplistic decision trees to these classifiers, which take in the information and just give you a decision support telling high probability of this being a diastolic dysfunction, low probability. And you're going to play with such decision tools. The beauty of these decision tools is that it takes away the cognitive load, and experts can still work the same framework. Like you go to Cleveland Clinic, Houston, perhaps Alan Klein and other people can still do. But what about the common people, average in the community? We see a big problem. We cannot use this complex decision pathways. So using something simpler like that may be a way to look into the future. And recently what we did was, this is an interesting study, where we took that classifier and we put into the ERIC database. And we found that in the elderly octogenarian population of the ERIC database, this classifier was still working. And I was wondering why we didn't even put the age parameter into the classifier. How did it do it? And then subsequently we have done a dissection of the neural networks, and we found that there was a node which had learned automatically to regress the echocardiography variables and learn to automatically adjust it for the age, so without putting the age into consideration. So what I'm trying to say is that there is a lot of work that needs to be done, but there's also excitement that this could be an age or risk factor agnostic way to move ahead with some of this classifier. This is a recent work which shows the future moving forward. Well, we'll have to look into the communities. I think in tertiary care centers and outpatient clinics, by the time patients come, they are coming very late. So if you want to really look into risk factors and how they impact diastolic function, we'll have to do it in communities. And there you cannot just keep on doing echocardiograms. So we'll have to look into variables, ECG, and other ways to bring it. We'll have to look into how do we use point-of-care ultrasound in our clinical practice. Could diastolic dysfunction be extracted from that? And then, of course, we have the tertiary care center where echocardiography is being done. You are further elevating your diastolic function assessment. How can we do this? This was a work we just showed in Lancet. Well, we know that electrocardiogram is capable of diagnosing diastolic function, dysfunction, reduced ejection fraction, and these are some of the work and classifiers from Mayo Clinic and other places. We have been looking into that, where it is very clear that you can diagnose diastolic dysfunction using electrocardiogram. Perhaps we can use it for screening out into the community and then bring people in. And what is very exciting is this is a recent work which is coming out in Nature Cardiovascular Research, where we have been able to synthetically develop the tissue Doppler. And the picture here that you see is the red color is the ECG-based tissue Doppler. And on the background is the actual spectral tissue Doppler from the echocardiogram. And this is a work in 20,000 plus patients followed for over 10 years, where you can see the synthetic echo at E prime velocities are predicting death and survival. So there is a way for us to be able to predict who out in the community based upon the electrocardiogram using synthetic ways to examine echocardiography-based parameters and bring them in who needs it the earliest. And if we move further in our echocardiogram, in our clinics, we'll have to think about a paradigm shift, and these clinical trials are happening. Maybe patients will be doing their POCUS point-of-care ultrasound themselves. And from those ultrasound images, which are done from the point-of-care ultrasound, we'll be extracting tissue-level database, and this is called as ultrasomics or radiomics, which we take the texture of the images, and we can develop information from these moving images, which is equivalent to Doppler and beyond. In fact, this work which we did in JACC showed that it can give you extract out MRI level information as well. So there's a huge opportunity of how do we practice in the near future. But while we are moving ahead, there are lots of challenges, and this is a work we're going to discuss tomorrow in the debate. What are the challenges? But the biggest important information, I'm going to put it out here, is that whenever you look into large database and somebody who's developing AI, taking a huge bunch of information and developing a prediction model, there is a risk of what is called as the averaging effect. If you do not actually put in expert-level information, you just take the data dump from institutions, you will average out the intelligence in the model. And diastolic dysfunction is basically expert-level information. So we have to be very careful. Even if I'm putting out there that diastolic function algorithms can be developed, we have to be extremely careful of how we develop it. Just having a large database and dumping it based upon retrospective studies is not the answer. So we'll have to curate and really bring in the intelligence from the experts into the model. And therefore, there is a long journey ahead, but this is exciting. There is a future where we can look out for the early disease out in the community. Then there is the use of large language model, generative AI. And we have to work together with the industry, academia-industry collaboration to bring some of these tools for medical decision-making, particularly in our fast-paced clinical practice. Thank you very much.